Yes, we can hear you loud and clear.
Great. My name is Oliver Mweso. I'm a medical doctor by profession, and I'm a resident under the Zambia Field Epidemiology Training Program. I'm currently attached to the expanded the EPI section of our Ministry of Health. I guess that's about it about me. Yeah.
Thank you so much, Dr. Mweso. We're happy to have you. Dr. Dien?
Thank you very much, and greetings to everybody on the call. Dr. Francis Dien Mwansa from the Ministry of Health Headquarters. I'm the National Manager for the Expanded Program on Immunization. Glad to be part of this interaction.
Thank you so much, Dr. Mweso, and thank you, Dr. Dien, for your introductions. So in the interest of time, I'll quickly invite Dr. Mweso to lead us through the first presentation, where we're going to be looking at the preliminary findings on the effectiveness of the COVID vaccines. So I'm sure a number of us have participated in that study that is ongoing. So I'll invite Dr. Mweso to lead us through that discussion and give us a bit more details related to that. So his presentation will be done in 15 minutes and will allow for another 15 minutes for questions, discussions, and clarifications. Thereafter, we will have the second presentation, which is done by Dr. Dien Mwansa, and we'll look at the community dissemination of the COVID-19 vaccine and the strategies that are being implemented to enhance vaccination. So Dr. Mweso, over to you. I'll share the screen from our end, and then you will guide me when to transition through the slides. Please confirm if you can see the slides in slideshow mode. Dr. Mweso.
Yes, I'm able to see.
All right, thank you so much. You may take it away.
All right, okay, thanks. All right, so I'll just give you a rundown on the SARS-CoV-2 vaccine effectiveness study amongst healthcare workers in Zambia. This is a study that we've been doing for the past 2 months, and we started off in July of 2021, and the study actually was covering a period starting from the 1st of July 2021, and we expected to run this study for the next 6 months, depending on how our sample size, how well we meet our sample size. So to start off, I thought it would be important for me just to run this poll question and see what kind of information is out there. So I can read out the poll question, and then I'll give a few minutes for people to give responses. So the question is, what is the overall SARS-CoV-2 vaccine effectiveness against symptomatic COVID-19? And option A gives less than 50%. Option B is 50 to 70%. And option C is 70 to 95%.
Okay, dear network, that is poll question number 1. I'll give a few seconds for people to respond to this poll. Already I can see there's some interesting voting patterns going on, and just about 60% of the participants have voted. So I'll just wait for the other participants to give in their voice. The number is a bit small, so encourage everyone to vote so that we have a background. Okay, so I will end the poll and share the results. So Dr. Mweso, that's how the network has polled, where we have About 50% of the network thinks B is the correct answer, and 42% think C is the correct answer, and the rest thought A, less than 50%, was the correct answer. So I'll hand over back to you, Dr. Mweso, so that you take us through. Dr. Mweso?
Sorry, I was muted. Can you hear me now?
Yes, we can.
Great. I was saying those are very interesting responses there. So I'll go straight into trying to answer the question that was posted. And to start with, we know that COVID-19 vaccines have been shown to be highly efficacious. And this ranges from anything below 60% to an average of about 80% against symptomatic COVID-19. So there has been demonstrations from studies done in Israel, Qatar, Denmark, UK, and other parts of the world that COVID-19 vaccines are actually efficacious against symptomatic COVID-19. However, we have seen positive studies on vaccine effectiveness in the real world setting, more so in Africa and sub-Saharan Africa setting. Ladies and gentlemen, I would like to take this opportunity to announce to you that we as Zambia are at the frontiers of acquiring this knowledge, and it's very exciting that we will be able to give some more insights on what the vaccination profile is like in Zambia. Next slide. Next slide, please. Thank you. So what we have, or what we know about vaccinations so far, is that we have over 30 vaccine effectiveness studies that have been published the world over, and sadly, none have come from Africa. The trend has shown a wide range of poor vaccine effectiveness for individuals who've received dose 1. That poor vaccine effectiveness has ranged from 60 to 70%. And we've also seen a 2-dose vaccine effectiveness range from 80 to 90%. However, it is important also to note that vaccinated persons could have breakthrough COVID-19 symptoms, and they may transmit. We should know that due to the milder and shorter course of the vaccine, the COVID-19 trend that the person may have after vaccination, they are more likely not to spread infection as opposed to someone who has not received any vaccine altogether. Next slide. So through the variants of the 3 waves that we've experienced so far, we've had certain variants of concern that we have detected. As you may know, we've had 3 waves in Zambia so far. And the variants of concern in these waves have been the wild type variant in wave 1, the beta variant in wave 2, and possibly the delta variant in wave 3. Though we do not have genomic sequencing that has been published at the moment, but what it's indicating now is that we may have the Delta variant. Regardless, vaccines remain highly effective against all known variants of concern. And there's been modest decrease in vaccine effectiveness observed for some variants of concern combinations, Like you can see there in the graph that I'm showing there, you can see that the combination of the Delta variant and Pfizer vaccine being used and AstraZeneca shows that in dose 1, you may have limited vaccine effectiveness, which is below 50%. But as you complete your dose 2, your vaccine effectiveness, the vaccine effectiveness tends to increase against the Delta variant. So it is imperative, and the message that I would like to put out there is that we should be able to complete our vaccines to get a very good vaccine response towards these different variants of concern. Next slide, please. So we have noted that the Delta variant has shown reduction in antibody neutralization. And this has been demonstrated in the lab. And some of interest here is the AstraZeneca vaccine that has been appreciably administered amongst our population. For an incomplete dose, we see a vaccine effectiveness of approximately 30% against Delta, and a complete dose showing 67%. This is as evidenced by a study that was done in England. That's the quotation you are seeing down there on the screen. And this still underscores the importance of a complete schedule of vaccine doses. The pooled effectiveness of these vaccines in preventing serious illness, hospitalization cases, and mortality is estimated at slightly above 90%, and this is still significantly high. Next slide. So now I'll bring you to my poll question 2. And in this poll question, I would want to know what is the percentage of hesitancy amongst healthcare workers to receiving SARS-CoV-2 vaccines. Is it less than 20%? Is it 20 to 50%? Is it greater than or equal to 50%?
Okay, thank you so much for that poll. So, dear network, I'll give 30 seconds for people to vote. We have well over 60 participants on the call. I invite every one of us to take part on the in this poll. So quite interesting polls that are coming in so far. We have people that have that think all the answer. There are people that think A is the correct answer, and we still have also a percentage that thinks B is the correct answer, and others that think C is the correct answer. So we are waiting for you who hasn't polled to give us your thoughts. So Dr. Mweso, as you can see, the voting pattern is quite interesting, where it's weighted towards one side, but you cannot tell where the majority of the participants are falling. Okay, just 10 more seconds to go. We're waiting for you to give us your opinion, and then I'll close the poll. Okay, so let me just share the results so that the network can see how we fared on this current poll. So we had about 52% that thought more than 50% is the percentage of hesitance among us healthcare workers, and 43% thought it ranged between 20 and 50, and the rest thought it was less than 20%. Dr. Mweso, over to you. Let's hear more about this.
Thank you. Next slide, please. So a study done, and that was led by Emmanuel Tembo, one of our field epidemiology residents in Zambia, over the period of March 2021 to April 2021, reviewed the variable willingness for uptake of the SARS-CoV-2 vaccines amongst healthcare workers in Zambia. So there was a question that was posed, and this question was, as you can see in the diagram on your right, the question said, if a vaccine against COVID-19 were available today at no cost, how likely would you be willing to get it? And from the responses there, we see, if you look at the legends there, absolutely certain is in blue, and the extreme response, which is not likely, is in green. You will see that there's not much difference from the 30% and 28%, showing an equivocal response. The second question also goes to say, do you plan to wait and see if the vaccine is safe and then take it? You can also see an equivocal response there, and this translates to a 50-50 response amongst healthcare workers. This also translates a negative impact on us acquiring good vaccine uptake in Zambia, and also contributes to lack of knowledge on vaccine effectiveness in our local setting. I am hopeful that a repeat survey that I have heard is most likely going to take place may yield more positive results. Next slide. What do we know about the impact of COVID-19 in Zambia? Like most other countries in the world, Zambia has not been spared from the COVID-19 pandemic. We continue to experience an upward rise and trend of new and repeat infections. And currently, as of 24th September 2021, we are just well over 200,000 cases and well over 200,000 cases and over 3,000 deaths. The good news is that vaccines are available in Zambia, and efficacy and effectiveness studies around the world have shown that we do have sufficient protection. Therefore, it is imperative that we conduct local research with regards to the effectiveness of these vaccines, and then we'll be able to answer very important and pertinent questions. Why should we conduct this local research? A question may be asked. One thing we should know is that our epidemiology is different from the Western world. As we all may know, we have a higher burden of infectious diseases, we have a weak health systems, and also poverty is very much stringent in our environment. Next slide. Our study objectives were divided into primary study objectives and secondary study objectives. Our primary objective was to determine the vaccine effectiveness of a complete schedule against lab-confirmed symptomatic COVID-19 amongst healthcare workers. Our secondary objective was to get a vaccine effectiveness against severe COVID-19 disease, vaccine effectiveness by vaccine product and combinations of different vaccines, and for 2-dose vaccines, vaccine effectiveness for a single dose and by interval between doses. For 2-dose, that is for 2-dose vaccines. And we also wanted to look at the vaccine effectiveness against SARS-CoV-2 variants. Next slide. This project is a test negative study design, and our plan is to make sure that this project can be completed in the next 6 months. And this would depend on vaccine uptake and also the sample size achieved. So a test negative study design is one that has been well described in influenza vaccine evaluations. And in this case, we're also using it in post-introduction vaccine evaluation for SARS-CoV-2. And the principle behind is quite simple. We come up with a case definition just to evaluate who fulfills the criteria to be part of the study. And when we do that, we categorize participants into either test positives, who will be called cases, and also those who test negative, who will be called controls. So for our data collection, we have been using a questionnaire, and it's got various sections having demographics, vaccine history, test results, and clinical history. We also want to do genomic sequencing And so far, we've made some progress in that respect, but we're still having some challenges here and there. Our analysis, we use a multivariable logistic regression model, and our vaccine effectiveness will be 1 minus the adjusted odds ratio for vaccination. Next slide. Out of approximately 695 healthcare workers that we recruited, we had an almost equal distribution of cases to controls. And we also had an almost equal distribution of vaccinated against vaccinated. And as you can see on the flowchart on the right, this is depicted showing a breakdown from the 720 healthcare workers that we had approached. And we came down to the symptomatics, and this is our population of primary interest. Please keep in mind this 454 symptomatics, which I'll be referring to from time to time. Next slide. This brings me to poll question number 3. What is the sex distribution of symptomatic COVID-19 amongst healthcare workers? Option A, male less than female. Option B, male equal to female. Option C, male more than female.
A very interesting poll question. I'll just go through it. What is the sex distribution of symptomatic COVID-19 among healthcare workers? Choose one answer. Is it males are less than females as option A? B is males and females are the same. C is there are more males than females. Okay, so I'll invite you to take part in the poll. So far, less than half of the participants on the call have voted. So I'd like to get your thoughts on this one. I can see some are saying the number of males and females is the same. And still quite a number that think there are more females than males. And another proportion is saying there's more males than females. So there's a bit of a tie between two of the three answers. I'll not reveal, lest I influence the voting. Okay, just 10 more seconds to go. So 53 out of 81 participants have voted. Invite everyone to participate on the call so that we can have a fruitful discussion. So we have 5 minutes to sum up this phase of the session before we get to Dr. Dien. So I'll end the poll in the interest of time and share the results. Sure, Dr. Mweso, you were seeing the voting patterns. You may speak to this poll question and the subsequent slides.
Great, thank you. So we see there that the edge was uniformly distributed between symptomatic cases and controls. I'd like for you to focus your attention on symptomatic healthcare workers in that table. And then a higher representation of the female sex was observed. So in that poll question, we see a higher representation of the female sex in our study. And this was more so amongst the cases. We observed a higher number of symptomatics from Lusaka than any other province. We had more comorbidities amongst symptomatic cases. And interestingly, the cases had a higher percentage of history of prior COVID-19. And this goes to strengthen the findings of the SARS-CoV-2 reinfections prevalence study that was earlier disseminated on this platform. Next slide. This slide is important, and it depicts the importance of timing of vaccination with regards to vaccine effectiveness. Colleagues, as you may know or recall, vaccines need time in the body to take effect. And this time has been shown that it's 14 days, at least for COVID-19 vaccines minimum. So a participant who is administered a vaccine more than 14 days before testing, we consider these as vaccinated. at the time of testing. Then we had participants that were administered the vaccine 0 to 13 days before testing. And these were considered to have an unknown immune status because we couldn't categorize them as either vaccinated or unvaccinated. Then we had participants who vaccinated after testing, and these were taken as unvaccinated because the vaccination happened after the date of the testing. So we had this distribution, as you can see in the table before you. Next slide. After adjusting our data for age, sex, prior COVID-19 diagnosis, province, and test week, and analyzing for vaccine effectiveness for one or more doses of vaccines administered, we determined the vaccine effectiveness estimate amongst healthcare workers with SARS-CoV-2 infection, and also those who are symptomatic with SARS-CoV-2 infection. And this came out to be 52% and 43% respectively at a p-value of less than 0.05. This is within range with the other estimates that I had shown you earlier from the other parts of the world. So the uptake of vaccines is currently ongoing within the country, and this may not be conclusive. We still have the other objectives that we need to answer to. Next slide. What does this evidence show? So the evidence from our study thus far has shown that SARS-CoV-2 vaccines confer protection against COVID-19. And this is in context with the studies that we have seen around the world. And we are very much optimistic that this locally generated data should encourage a more robust vaccine uptake amongst the Zambian population. We know that this study is ongoing and we have to address all the study objectives. We would like for the increased uptake of vaccines, health-seeking behavior once one falls ill, and also clear documentation of data, storage, and also retrieval of samples, as this will help us answer the questions that keep burdening us over vaccine effectiveness. And these questions can be answered by ourselves. I thank you for your time and listening. I end here. Thanks.
Thank you so much, Dr. Mweso, for taking us through this interesting study and sharing the preliminary results for this study. So at this point, I'll just allow for a few minutes for questions, clarifications, or concerns. So you may put your questions in the chat box, or you may raise your hand, and I'll be sure to give you a platform to ask and speak. Okay, so far there are no hands. It seems to suggest that majority of the participants understood what you have presented, Dr. Mweso, or there's still a lot of confusion that we don't know where to actually focus our questions on. But it's quite interesting to note the findings that you've highlighted in this study. And we are very optimistic on learning what the full study is going to reveal with respect to the vaccine effectiveness. Any questions, comments, concerns? Okay, so it seems like there are no comments, no questions. I think at this point, I'll quickly rush to invite Dr. Dien Mwansa to start basically giving us preliminary talking points on his presentation, and we'll have his slides shared in no time. Dr. Mwansa, over to you in the interest of time.
Dr. Sinjini, as we are waiting for the slides, is it possible for us to go through the polls just quickly?
Definitely, that's a good suggestion, Dr. Sombo. Let me just take you back to the first poll that we had and see if learning has really occurred. So poll question number 1 was, what is the overall SARS-CoV-2 vaccine effectiveness against symptomatic COVID-19? So option A was less than 50%, B is 50 to 70%, and C, 70 to 95%. So I invite the network to give us your thoughts on this poll. What is the overall SARS-CoV-2 vaccine effectiveness against symptomatic COVID-19? So I'll give it 10 more seconds, and I'll then invite Dr. Mweso to just comment on the results. We're seeing an interesting voting pattern. It's quite similar to what we saw in the initial run of the poll. Okay, so there's only 27 people that have participated out of the 86 on the poll. In the interest of time, I'll end the poll and invite Dr. Mweso to comment on the results and re-emphasize what the correct answer is. Dr. Mweso.
Thank you, David. So it's a bit unfortunate. The correct answer is actually C. So the overall SARS-CoV-2 vaccine effectiveness against symptomatic COVID-19 lies just above 70%. So we're looking at having completed a complete schedule. We're not looking at someone who's received dose 1 only. So when we say the overall SARS-CoV-2 vaccine effectiveness against symptomatic COVID-19, this is in reference to studies that have been done elsewhere, not our incomplete study. So we expect at least a response of C.
All right, thank you so much for that feedback. Let me quickly move to poll question number 2, and let's see if learning has occurred. What is the percentage of hesitancy among its healthcare workers to receiving the SARS-CoV-2 vaccine? Option A was less than 20%, B was 20 to 50%, and C was greater than or equal to 50%. Okay, I invite the network once more to vote. Just want to assess if learning has occurred. Okay, I'll just give it a few more seconds. There's poor participation in today's echo session. I'm wondering why. Is it that the subject was not very clear, or people are eager to get to the next presentation? But we have an interesting voting pattern. Allow me to just quickly end the poll and share the results. And Dr. Mweso, you could speak to that voting pattern.
David, thanks once more. I'm getting a bit scared. Probably my delivery was not so well. So for this one, as you saw when I posted, there was actually 2 extremes. There was an extreme of people who are willing to wait, and there were others who are absolutely certain that they would take up the vaccine. So if from let's say 100 people, you find that 50 were sitting the other way and 50 were sitting the other way. So that, it was actually slightly over 50%. So the correct answer would be C. The hesitancy amongst healthcare workers to receiving SARS-CoV-2 vaccine is actually on the negative side. So it's greater than or equal to 50%.
Thank you, Dr. Mweso. I'll quickly run through to poll question number 3 and relaunch it so that we can also assess if people really paid attention to your discussion. And while we are at it, I've noted the questions that are in the chat box. I will get to them in a moment. Question number 3 is, what is the sex distribution of symptomatic COVID-19 amongst healthcare workers? Option A was there were more females than men. That is, the males were less than the females. The distribution of the males and females was equal. And C was that there were more males than females. Once more, dear network, I invite you to participate in this poll question so that we can just assess if learning had occurred. So I will be quick to end the poll and share the results and invite Dr. Mweso to quickly comment on it. We are slightly behind time. Yes,
Thank
Dr.
you,
Mweso.
David. Thank you, David. This response is actually correct. We had more females than males who presented in our study.
All right. So thank you so much for taking us through the poll questions. And already we can note some areas where there was still a bit of some lacunas amongst the participants. So quickly, before we get to Dr. Mwansa's presentation, there's a question in the chat box coming from Dr. Mwansa, and he asked, say, knowing that when the third wave started, most people had only received the first dose and some people got sick. Did that have any impact on your findings? Dr. Mweso, you can speak to that.
Yes, most definitely, because we couldn't analyze for the second dose because most people at that time, as you know, we just started giving our vaccines in April this year. So by the time that the third wave was coming in, most people had only received one dose. And so that is why in my analysis, I had just focused on the one dose. But rest assured, as we are going forth, we will have sufficient numbers for the second doses, and then we'll be able to make a good analysis then.
All right, thank you so much. I think there's a bit of, there was a concern that was raised by someone in the chat. Say, how can we motivate healthcare workers to receive the vaccine, considering that they are at high risk? I think that's a discussion for another day, and probably Dr. Mwansa may speak to it in his presentation. So allow me to quickly invite Dr. Mwansa to take us through his presentation, and then we'll have a discussion afterwards. We'll share the slides from our end through our ICT team. Dr. Mwansa.
Thank you very much, Chairperson. As the slides are coming up, quite interesting discussions and quite interesting to see the shift in the learning. I was thinking to myself when I was seeing the last question that probably people have seen that from the administrative numbers, that there's actually been more males who have gotten vaccinated than females, which can easily be confused with more females showing up in the study than the males. I might not exactly speak to the last question that you've asked about the motivation of the health workers. But I think it is important to recognize that maybe that one slide I remember in this presentation, then I can delve on that so that I do not take much of the time. Instead, go straight to the presentation. So I can have the next slide. When we started, I want to tell a bit of a story about where we are coming from, just maybe 3 or 4 slides, and tell a story again about where we are and where we are going. So when we started, these are the questions people were asking. How are we going to start? When are we going to start? And who is going to start? Those were the 3 main questions. Remember, it was at a time when the ventilators was a main issue. Social media was abuzz with speculation of how many ventilators we had. No, ETH has 2 ventilators and things of that sort. Next slide. Fortunately, we did not get to this state. I think the slides are moving quite slowly. Fortunately, those are historical. We did not get to this state. For those that have followed the immunization program, as it were, this was a site in the 40s, 50s, 60s, 70s, and 80s. This was a site in the sense that these, let me call them loosely ventilators. for polio patients. In fact, at that time, we were saying, given the direction we are going with COVID-19, we'll start having words like this. We can move to the next picture as well. It gives a slightly different view, a closer view to this. I must say that fortunately we have not gotten to this, but we could get to something like this. Next slide. So we started, and I think the next slide should be able to show us the first picture of the Honorable Minister, then the former Minister of Health, Dr. Jonas Chanda, participating in the first receipt of the vaccines. And this was, I know it has been said that the Honorable Minister was the first person, but this was the first person who got the vaccine in the country. Next slide. And this is pretty much the summary of where we are coming from. I think if you look to your left with the declaration of the pandemic on 11th March, fast forward to where we are today, I think much of what we have in here are timelines and milestones that people are familiar with. But fast forward to where we are today, right now, we've reached a point where we've had a look at the program. And I think some of the slides I'll share might be able to answer some of the questions like the one that was asked about health workers. In that, we've looked at the program implementation in 7 provinces through a process called the interaction reviews. And we've also conducted 1 interaction review. There are a number of things that have prompted us to start discussing a campaign now, and I hope in the next few slides, the picture gets clear. Next slide. So before I get to that, I thought of reminding people that from the outset, even before a dose arrived in the country, we set out 9 principles for the COVID-19 vaccination. These have never changed. We advocated that our program be voluntary, just like all the other vaccination exercises. Whilst it is voluntary, we advocated also that all eligible persons will be encouraged. I know some people have thought it's because of such principles that the coverage now stands at 4.3%. If we made it like our southern neighbor mandatory, maybe it would have been different, but I think we can discuss that some other time. We also insisted that this became a 9th pillar within the national COVID-19 response. We also developed a document called the National COVID-19 Vaccine Deployment Strategy, which was built on the principles or the platform of routine immunization. We've continued to improve the platform upon which this is sitting through a health system strengthening approach. The last pillar is highlighted in red for a very good reason. It is one of the pillars that admittedly we haven't done so well, and I'll speak to it. Next slide. So that's where we're coming from. Now, where are we right now? Next slide. So if I speak to where we are right now, I think this is public knowledge because each time all these antigens have come through, there has been a public display of these vaccines at the airport. And these vaccines have been received on the dates indicated on the left. The quantities are indicated on the right. However, there is one that was received last week, Friday, that is not appearing here. AstraZeneca received from Norway 124,500 doses, which has simply moved so far the vaccines that we have received in the country to 1,245,300 doses that we have in the country. Next slide. So we have also tried to look at the vaccination program itself. And for those that will have access to these slides, there are 4 or 5 other slides of this nature, but I think this is just an example. We've tried to look at how the vaccination program, responded based on the vaccine antigens that we received versus the most recent wave. So what you see in blue, deep blue, that is the 3rd wave. So what you get on this side, I don't know if in my case I can be seen, but this should be orange. This is when we started. This is a period of around 12 days when we had the majority of the AstraZeneca doses given. On either side of the 3rd wave, you see another peak when we recommenced, because we had a pause of about 32 days, when we recommenced again, the orange you see, that is AstraZeneca peaking just when the third wave was slowing down. And then you will see in blue, no, that's green. In green, the combination of when we started giving the Johnson & Johnson and the second dose for AstraZeneca. So 2 things important to take note here is that we actually have never had an overlap between waves and the vaccinations. The peaks of the vaccinations have been on either side of the third wave. Secondly, is that we have had trouble getting people to get the second dose. Look at this line here. I think if it's an ECG, Dr. Sombo would probably be certifying this person here. And this is part of what we intend to address. Next slide. Next slide, next slide. So I think that was just to emphasize that ECG for Dr. Sombo. Next slide. I think I might skip this because this is just administrative information, which I think everyone gets through the statements released by the Permanent Secretary and the Honorable Minister of Health. But I think just to emphasize what I spoke to, that if you can quickly press the next slide so that I highlight the areas of interest. So this is what we got yesterday. These are the cumulative numbers. Next slide. The cumulative numbers here, and cumulative, this is where we are. I said 4.3, in fact, it's 4.4 fully vaccinated so far. And then these are the doses that we have actually received. Remember, I mentioned the 1.245300 that we have, having received the 124,500 AstraZeneca doses on Friday last week. Of that, we have used 59% of those vaccines. So just do a subtraction between these two, you get about 510,000 doses that we have in country at the moment. But I'll speak a bit to that again. Next slide. So then, given that scenario of where we are, I think now it's important to go to where we are going. And this is the gist of this presentation. Next slide. So a set of concerns that have led us to where we are. Remember, I highlighted our 9th pillar as not having done too well. What we have realized is the following. Next slide. One is, even where you are, at home, at church, at school, at the market, I will challenge you. Just ask any person near you. You will be hard pressed to find a person who is older than 5 who does not know what COVID-19 is. Everyone knows. And when people don't put on masks and don't do as guided by the 5 golden rules, people know. At least they know, which is very important. So you'll be hard pressed to find a person who doesn't know what COVID-19 is, a person who doesn't know what COVID-19 does to people. People know what COVID-19 do, and a person who doesn't know how to prevent it. People know, but we'll have to continue hammering that message. However, next slide. Again, within the same vicinity of where you are, it will not be very difficult for you to find, including health workers, to find even health workers or persons who do not know what a vaccine is and what it is not. A person who does not know what a vaccine does, and specifically COVID-19 vaccine, what it does and what it does not do. You don't have to go far to find a person who actually doesn't know where to access the vaccine and how to access it. This is problem number 1. There are just too many people without this basic information. And we can look at the contrast between the disease and the intervention. Next slide. What we also know clearly is that I think we have done quite well insofar as communicating the disease, as I've demonstrated about, and I've seen a couple of surveys done, and it's quite clear that we have not done well in communicating the intervention. Next slide. The second set of concerns that we have, which has brought us to where we are, is that I did mention that we have, next slide, we have some vaccines with quite a short shelf life. But before I focus on that, this country adopted 3 targets. 1, we agreed to the AU targets that we will vaccinate up to 10% of our eligible population. For those that have followed, our eligible population is 8,435,515 people. Of that, we said 10% would have been vaccinated by the end of September, and 30% of those would have been vaccinated before New Year's Day 2022. And then 60% at that time. This number just changed last week as guided by the AU. AU has changed the number from 60%, and all countries now have adopted 70% of the persons targeted should have been vaccinated fully by 30th June. However, next slide, where we are is that we having vaccines come in 3 ways. We have donations, we have the COVAX facility giving countries like ours for free, and our own countries buying the vaccines. The majority of the vaccines that we've received are donated ones. You will be hard pressed to find vaccines being offered to a country with a shelf life longer than 60, lucky 90 days. So most of those have a short shelf life. We have about 48,000 doses that have a shelf life of the end of next week. And the 124,500 that I spoke to earlier as a shelf life of end of next month, and so on and so forth. The vaccines that exist out there have a shelf life. And I think it should be understood that this is how the vaccines world operate. When a new vaccine has been made, the shelf lives are shorter. But as we go, and particularly if the platform is new, the reason you'd have Sinopharm, for instance, having shelf lives of up to 2023 is because Sinopharm is using an already established platform for its manufacturing. For instance, the mRNA vaccines have never been made before. So you cannot have an mRNA vaccine with a shelf life of 2023. It will be unscientific. Next slide. So even with these numbers, what we know, given those targets up, is that Zambia needs more vaccine doses. Next slide. And I've spoken to the Sinopharm, which has shelf lives of 2023, because the platform used for making Sinopharm is similar to what we've had with other vaccines such as measles, polio. Next slide. So given that background, it is important to also look at the overall program. I won't bore you with the details, but I have to report that, next slide, that we've had a look at the males versus females, and particularly in the last 6 weeks, to see whether there is any difference in terms of males coming more than females. No difference. We look at the provinces. Is one province doing better than the other? No difference in terms of what they are doing proportional to the vaccines they have. Looking at the professions, are teachers doing better than health workers or the reverse? No difference in the last 6 weeks. Next, by age, are the young ones doing better than the elderly? No difference at all in the last 6 weeks. When we look at the comorbidities, are people living with HIV doing better than those with diabetes, or the opposite, or other conditions? Again, no difference. And so on and so forth. So that information is important to bear in mind, because we then basically are saying that we need to act to have some difference in the system. We've gone further to look at our very own system. Next slide, to see how that ties in. So let's look at the vaccines, for instance, side of things. One, what we know is that at the moment, that 510,000 doses in country estimated, those vaccines are distributed proportional to the size of the provinces. So if I display the provinces' population and the vaccines, you'll see that it's proportional. But Sinopharm has only been distributed to Kitwe and Lusaka for a number of reasons. Two of them are that these were the only districts that had administered Sinopharm before, through the program with the Chinese, before we got the 100,000 doses. I have to also mention that the AstraZeneca that we received on Friday last week, the 124,500, has gone everywhere. And we're hoping that by tomorrow, every province would have received. If there's anybody from Western Province, for instance, listening, they would know that we have not yet given them. The aim there for next week, as we do the campaign, is to consume all the 510,000 doses that we have. I know somebody like yesterday asked to say what happens to those who will be due for the second dose the other week. Let me speak to 2 examples of what is in the pipeline. Soon, we should be receiving, and soon I'm talking about less than 2 weeks, we should be receiving 580,320 doses of Pfizer. We now have the requisite cold chain at national level, minus 86 degrees that we'll be using. We also have in the pipeline, just waiting somebody's signature somewhere to get the 432,000 doses of Sinopharm. And we also have those vaccines that the government has procured from the Africa Vaccine Acquisition Trust that are coming in. I've steered clear of mentioning numbers here because numbers often start from the bosses mentioning them before I come through, but let me say substantial amounts of vaccines. In a nutshell, by mid-October, we will have over 1.5 million doses of the vaccines in country. By the end of October, we would have received, aside from what we have already, which we hope to exhaust next week, over 2 million doses. So this is another reason why we are moving in the direction we are moving. Otherwise, we'll have a lot of vaccines that will not be moving. Next slide. So given that we are running a 2-day campaign, we call it a catch-up campaign. The initial thought, and that is Monday, Tuesday next week, the initial thought was that this week we should have done some micro-planning. It's highlighted in red because that activity has been postponed, not cancelled, but postponed. Given the quantities of vaccines that I've spoken to that we are going to receive, we cannot cancel. We need to plan properly through our micro-planning process, otherwise it will be catastrophic. We envisage to work with 500 teams. This week we've learned that actually across the country, we have 799 teams that we are working with. These are teams for which we have raised resources, and resources should be on the way for them to conduct this activity. Next slide. So basically that in red is an aspect that has been postponed, not cancelled. Next slide. And this is how we envisage to do the micro planning. But I think in the interest of time and the fact that this is a postponed activity, you will allow me to move to the next slide. Part of the package, yes, that is postponed. Thank you for that. Part of the package was also meant to start with relaunching the advocacy, communication, and social mobilization. And I have to emphasize here, these three pieces are distinct and different. Advocacy, communication, and social mobilization. Sometimes people confuse seeing somebody on TV that they are social mobilizing, they are not. So quickly, when we get to inform the key gatekeepers, the traditional leaders, religious leaders, political leaders, civic leaders, prominent people in community, we inform them. Health workers, they get to be informed about what is going on. That's simply the definition of advocacy. We think that we have done some level of advocacy, probably to the tune of 70%, but we haven't done enough. Especially that you still can find a health worker who does not know the questions I asked about. Communication, predominantly, we have had radio, TV, Zanis going around with PA systems, flyers, and some frequently asked questions thrown around and posters. Those are the means of communication that we've done. I don't think we have flooded our spaces as much as we would, particularly social media. I think there's been some poverty of information on social media. We wish to change that. The social mobilization, the only difference with communication is that social mobilization gives you an opportunity to do two things. The person you are selling the information to can ask questions. They cannot ask a flyer questions or a poster questions, or they can't stop Zanis and start asking questions. So that is just communication. Social mobilization involves a discussion. That we haven't done well, because that means we'll need to have people on the ground. So this is what this movement is about. On the advocacy front, later in the week next week, we will have the Honorable Minister of Health receive the first dose of a COVID-19 vaccine in a ceremony at Ndeke House. And I think, let me not preempt too much, because the Honorable Minister herself will tell the story. So this is part of the plan. But because of what the concerns I've raised before, we can't wait until that event, which is happening on Friday. We'll have to go ahead with the campaign. Next slide. So with the campaign, this is what we aim to get out of the campaign, but I know I'm running out of time, so I'll skip this one as well so that I focus on the actual issues of the campaign. Next slide. Yes, so with the campaign, it is important to look at where we are, and we've tried to check ourselves with the 5 key areas of the program. If you can go through each of those areas that I'll quickly speak to before we see if there are any questions. So we've looked at our own coaching and logistics. Next slide. We've also had a look at our service delivery platform. Next slide. Our AEFIs. Next slide. We've also had a look at our M&E. And of course, we've had a look at the advocacy, as I've just explained, and finally, the financing for immunization. Next slide. So this is where we stand for each of these. On the coaching, next slide, coaching and logistics. We think that with 1.2 million doses of vaccines that we've received, our small footprint of coaching is adequate. Things will change as we receive the doses that I've spoken to, and that is why we are expanding. Service delivery, we have 799 teams across the country. What they have been lacking is financial support to do outreach. We think that what we are starting next week will change this trajectory. On the AEFIs, thanks to CDC that have been supporting us. In fact, they've gone as far as bringing in somebody in country that will help facilitate the appraising of the AEFI platform. And I think we are glad to have our national focal point person for AEFIs back on track. So I think we pretty much are good there. M&E has also not been bad, particularly that we are only talking about having reached out to less than 500,000 people so far, but I think things could change. I've already spoken to the advocacy, communication, and social mobilization and how A differs from C and differs from SM. What we need is more of SM, foot soldiers, foot soldiers, foot soldiers. Finally, thanks to institutions such as UNICEF, SIDA, GSS, Discover, that have supported all the activities for the districts next week. If there's a person from HQ listening and provinces, unfortunately, we could not manage to find resources for those. Next slide. So thank you very much. I've added a few additional slides, but I was worried that I might actually run out of time. Thank you very much, Chairperson. Dr. Singin, I think you are muted.
Can you hear us now, Dr. Dien?
I can hear you. I can't hear him.
Can you hear me now?
I can hear you now. Thank you very much.
Okay, thank you so much. I was saying it was very, very interesting presentation and quite exciting to look at the efforts that are being put in place and what we have in the pipelines to increase the vaccination coverage in the country. I think you know why my excitement is above the roof from previous discussions. So I was saying there's an interesting comment in the chat box coming from Dr. Mwansa about the presentation that you have made. Maybe I'll invite Dr. Mwansa to unmute himself and just ask his question and seek the clarity. Dr. Mwansa?
Okay, thanks for the opportunity and thank Dr. Mwansa for the presentation. So I've earlier made some comment in the chat based on what we are getting on the ground. So the first issue is there are few concerns that people are raising in terms of the source or the origin of the vaccine. People are bringing issue in terms of the vaccine that we are getting, if they are from China, for example, or from India, they are not accepted in other countries that you may need to address. There are issues also in relation to the pharmacovigilance, especially in terms of long-term advent event of the vaccine that may require also to be included in community sensitization. Then there is also the issue of availability of the vaccine at the vaccination site. So in some facilities, even if some clients want to get the vaccine, so the supply has been a challenge. Also, any plan to have extended hours in terms of vaccination program or 24 hours so that clients can have access to the vaccine. Then the last, not the least, it's about the data management. How often are we conducting QC in terms of the data that is being generated, as well as in correcting some of the errors? So for example, I can talk about myself. I went in the system and checked my record in terms of vaccination. Then I realized that actually the site that I'm appearing to be vaccinated is not where I got the vaccine on. And when I interacted with the staff on the ground, then they are having some challenges in terms of correcting the data until you go back to the site where you got vaccinated, and that's where they can correct the data. Thanks. Over to you.
I can't hear you, Dr. Singini.
Thank you so much, Dr. Mwansa. I think I'll invite you to speak to those questions and concerns raised by Dr. Mwansa. Thereafter, I'll ask Dr. Sombo, who's here in the hub with me, to ask her question.
All right, thank you very much, Dr. Mwansa. The first one is related to the origin of the vaccines. Probably the next time I use that slide, I'll add the origin. Remember the slide that was showing each of the shipments that we've had? Yes, the very first vaccines that we got came from India. The AstraZeneca called Covishield came from India, the 228,000 doses that we got. And I think we've had vaccines from Spain, France. The one that we received on Friday, 124,500 came from Norway. The first Johnson & Johnson vaccines we got came from the USA. And then we also had Johnson & Johnson from Denmark. The Johnson & Johnson that we received through the AVAT, the ones government procured, came from Denmark. I think of those antigens that we've received, one that I think raised some issues before was the Covishield one, the one from India. I think if you allow me just in 20 seconds, I can explain how this works. It has to do with the regulatory authorities. The Europeans have something called the European Medical Agency, EMA. So what regulatory authorities principally do, and that's their ZAMRA, by the way, is they regulate what products come in a particular jurisdiction and what products can be used in that jurisdiction. And so what happens is that the person manufacturing that product, this is not only with vaccines, but drugs, has to go to that authority and register. So if, say, for instance, you bring in a vaccine that is not registered by ZAMRA, ZAMRA will not recognize it. And from ourselves, we will say, you got a vaccine that is not recognized, so to us, you are not vaccinated. And I think that was what the issue was with Covishield, that Serum Institute of India, the manufacturer of the same AstraZeneca, which is also manufactured in Europe and manufactured in South Korea, had not registered the product from India. And so there was that communication that a person who got Covishield, the AstraZeneca from India, would be considered as not being vaccinated because that product wasn't registered in Europe. But I think that is a changed story. Covishield is now registered with the European Medical Agency, and persons who got that vaccine get recognized as vaccinated. The new issue that has come in with the UK government is totally different. It is different from the type of the vaccine. The UK government deciding that any person from Brazil, Africa, Qatar, and all those countries who go to the UK is considered as unvaccinated, has nothing to do with the vaccination, but the certificate. As you would know, in Zambia, we do not yet have any person who has received a COVID-19 certificate. What people receive, do I have it here? What people receive vaccination record cards. Now, what the UK noticed was that there are people coming from Africa going to the UK with a vaccination certificate. And when they inquire from us, we tell them we don't issue any vaccination certificates from Brazil and so many other places. So they said until there's harmony on the certificate, any person who got the vaccine elsewhere is considered unvaccinated. So you'll have to understand that it has nothing to do with the vaccine and where it is coming from, but the fact that, and the reason it has delayed for us in Zambia, we already have a template. Thanks to M&E, they already did an ICT. The reason is simple. What would be the use of giving a person a certificate and we don't have the means of ensuring that it is recognized out there? So what Zambia has done on testing, if you get tested today, there are accredited laboratories such that if you go to the airport, they check within the system, it will show them that Dr. Forosh got tested 3 hours ago. If you reach Bole International Airport in Ethiopia, they'll still check the system and find the same information. That platform does not exist for vaccines. So Zambia is waiting for the AU to launch what is called the Trusted Travel Platform for vaccines. Most likely they will use the same platform for testing, and then Zambia will link its database to that. Then you can be issued a certificate, which when you reach the airport, they scan the QR code, they find your information in there. So I thought I'd spend a bit of time on that just to explain. It has nothing to do with the origin of vaccines. The COVID issue was sorted. Pharmacovigilance and long-term, that's an important area, Dr. Mwansa, and that's why I mentioned that. I think we've turned the corner. It was also an area of concern for our partners, and thanks to CDC, we have had some support and some support that is continuing. Like I mentioned, we have even a person that is working with us to ensure that we streamline some of the problems that we had. The thought is that even for long term, we will continue with the AEFI surveillance so that we should be able to pick up any issues of concern. Even when it came to sensitizing people, so some of the things that people might be experiencing after getting the vaccines, the report, those things will be heightened. I think we take your counsel also on the reporting. So on that, it's just to admit that your observation is correct, and we think we are turning the corner. Availability of the vaccines in the sites. I did mention in my presentation that at the last count, and that should have been 6 weeks ago, we had 354 facilities providing COVID-19 vaccinations across the country. When we embarked on the program to do a catch-up campaign for the 3 reasons that I mentioned earlier, we thought we would work towards raising that number towards 500. But when we did our own situation analysis within this week, we learned that we actually have more sites than we thought we had. That in itself means that we have spread the few vaccine doses that we've had across almost 800 facilities. Now, what we are unable to tell in the absence of micro-planning and in the absence of uniformity insofar as advocacy, communication, and social mobilization is concerned, is who or where will the response will be better rather. So I can say, okay, the population from Chinga and say Luapula is the same. Let me give them the same amount of vaccines. Then after 2 weeks, Luapula finishes theirs. Mchinga is done with probably 80%. That we are unable to tell at the moment. So when we distribute equitably. But I think over time, we are realizing that some of the facilities, yes, are running out. At the moment, the focus is really to ensure that we exhaust the 510 that we have. As we get more and more vaccines, I think this issue will be a thing of the past by mid-October. This is just to acknowledge that, yes, we are now aware of some facilities that are designated COVID-19 vaccination centers that may have probably run low, particularly on the Johnson & Johnson. AstraZeneca have not had such a report. Extended hours remains part of the strategy, but maybe through the campaign into the course of the other vaccines that we are expecting. Right now, it is not part of what we're implementing, but I can assure you that is part of what we've put in place to handle. And finally, there was a question on the data quality, the quality control issues. I must say that thanks to our colleagues within the Department of M&E and the network that they have at provinces through the SHIOs and the DHIOs and some of the persons that handle information in health facilities, the start wasn't smooth. And the case that you referred to, Dr. Mwansa, I also experienced that. I got my first dose at UTH. A day before the launch, Dr. Follow should remember, I actually never appeared in the system until a month later. So I'll tell you that there were a number of things. I wish the colleagues from M&E were here. If they are here, probably one of them could comment. But I think I'll tell you that in the last 2 weeks, quite a lot of work has been done to clean that data, and they continually on a day-to-day basis, sometimes on a week-by-week basis, running quality control tests and cleaning up the data. In fact, one of the major issues now they are working on, which led to some of these, is that when people were going back to get the second dose, the person entering data will kind of have to log out of the first dose platform to go into the second dose platform, in a way that, from what they were explaining to me, tend to imply, depending on how the data is entered, as though Dr. Mwansa got the vaccine from facility B, when in actual fact he got from A. So what they have tried to do is now to have these two on a single platform so that there is no change of original data when the second dose is actually being given. I wish I could be a bit more technical so that it clarifies that, but I think my responses are being too long. Dr. Follow should kill me.
Thank you. Thank you for reading my mind, Dr. Dien. I think first of all, I want to say thank you to Dr. Mweso and congratulations to yourself and your team. Every time you join us here, your basket is getting bigger. Now you have Pfizer in that basket. I think that's a big achievement. I wanted to find out with the WHO recommendation that we can extend Pfizer to children as low as 12 years. Are they now in our priority population, in particular those that are at high risk of severe COVID-19, those with cardiac disease, hypertension, diabetes, and those with mental illness? Are they the targets for this one?
Yeah, two things you asked there. So decisions of that nature, Dr. Folloshi, thankfully, since 2016, I do not take part. I do not take part in those decisions. There's an independent group of people called the Zambia Immunization Technical Advisory Group. It's headed by Dr. Mwenechanya. So Dr. Mwenechanya and team are scheduled to meet to discuss that. Whether they adopt it depends on the evidence, or they throw it out as part of the recommendation. I think we'll be informed. We are aware of that WHO recommendation, but it's really not up to the Ministry of Health. There's an independent body of experts that looks at that information. So I might not have an answer for you. Similarly, in terms of who might be prioritized for these vaccines, Pfizer to be specific, there are special groups that are being listed. Again, that's a question for Dr. Mwenechanya. I don't even know if he's on the call, but he heads that group, an independent group of experts that make such decisions. Sorry to disappoint you, Dr. Folosh, but unfortunately I can't answer until they meet.
I wanted to tie your hands on this one, but you are very clever, but well done. Thank you so much.
All right, thank you.
Thank you so much, Dr. Mwansa, for this very enlightening session. So we're actually very excited with the insights that you've shared with us related to the route of the vaccination across the different districts. We're also very excited to note that there's a number of vaccines that are in the pipeline yet to come into the country. And like you alluded to, we may hit up to 2 million new doses coming into the country in the next few weeks. That is exciting news. It's the only way really to increase the coverage. At this juncture, I'd like to thank everyone that has taken part on this call. I must be quick to apologize that we have overshot way beyond the designated time, but you may agree that this was a very, very relevant subject matter. At this point, I just want to ask Dr. Dien to just give us one sentence of the concluding remark, especially to drum up support for the campaign starting next week. Dr. Dien.
One sentence is always difficult for me, but let me say it this way. The people on this call are probably the most important stakeholders. I have come to learn in 2021. What these people on this call say is what happens. It doesn't matter what we throw funds into. So you are the advocates for the vaccines. Ensure that you are as well informed as possible and get the correct information from the right sources. And we are grateful for your continued support. Thank you.
Thank you so much, Dr. Mwansa, and also a special thank you to Dr. Mweso for taking us through the vaccine effectiveness study preliminary results. Thank you to all the participants and the comments and questions that have come through. At this point, just want to encourage everyone on this call to get vaccinated, and let's encourage the next person to get vaccinated, because at the moment, it's the surest way to win the war against COVID-19. So thank you so much. Have a pleasant day. We are signing out.